with the publication this June of her new book on One Health and the Politics of Antimicrobial Resistance. She's now on a speaking tour almost every week from Romania to Washington, D.C. to New York City. So Dr. Kahn is a physician and research scholar with the program on science and global security at the Woodrow Wilson School in Princeton, Public and International Affairs. A decade ago, in April of 2006, she published a Sentinel paper called Confronting Zoonosis, Linking Human and Veterinary Medicine in the CDC's Journal of Emerging Infectious Diseases. And it was this publication that helped launch the One Health initiative that seeks to improve the health of all species by increasing communications and collaborations between human, animal, and environmental health specialists, us. She is the author of a book called Who's in Charge? Leadership During Epidemics, Bioterror Attacks, and Other Public Health Crises, which was published in 2009 by Prager Security International. She writes online columns for the Bulletin of the Atomic Scientists and has published in many peer-reviewed journals. Her second book, as I mentioned, just came out this June, called One Health and the Politics of Antimicrobial Resistance, published by the Johns Hopkins University Press. And this is it. Actually, we have some I can pass around. I'm sure that'll be fine. Thank you. She also teaches a course at Princeton titled, wait for it, Hogs, Bats, and Ebola, an introduction to One Health policy. And it received an award, a 250th Princeton Anniversary Award, Fund for Innovation in Undergraduate Education. On a personal note, I have to say Dr. Kahn invited me up very kindly last year to speak with her students for 3 hours about Ebola, and they were quite interested. I think they've been primed by Dr. Kahn to be interested for 3 hours about Ebola. Dr. Kahn is a native of California. She holds many degrees, including initially a Bachelor of Science degree in nursing from UCLA, then a medical degree from Mount Sinai School of Medicine, then a master's degree in public health from Columbia University in New York City, and then a master's degree in public policy from Princeton. She's also a fellow of the American College of Physicians and is a recipient of the New Jersey's Chapter Laureate Award. And in 2014, she received a Presidential Award for Meritorious Service from the American Association for Public Health Physicians. And this year, in 2016, received an award for the American Veterinary Epidemiology Society, their highest honor for her work in One Health, the K.F. Meyer James H. Steele Gold Head Cane Award. So please join me now in welcoming Dr. Kahn.
Thank you. Well, I can't tell you how excited and thrilled I am to be here because I've been seeing all the announcements for all these years, and gosh, I really want to go. So finally I'm here. I was supposed to be here last April, got the flu, so now I'm good. So anyway, thank you so much. I'm really delighted and really exciting, interesting, diverse audience, and can't wait to talk and meet with you afterwards. So let's see, how does this work?
Should be going. Let's see.
Okay, this one? Okay.
Right here, yeah.
Okay, great.
Yep.
So, yeah, so as Dan mentioned, my book came out this past June, and it has over 90 graphs and charts, which are available online because the publisher was not going to put them all in the book. So they're freely available online. And I'm sure you all are familiar with the One Health concept, but I think the subject of antimicrobial resistance is particularly apt for a One Health analysis because it is such a complex issue. So in the book, I looked at all these things and looking at antibiotic use and resistance, the history of why it was being used, livestock production, healthcare costs, global issues, environmental, and antimicrobial research and development issues. For the sake of time, because we're limited here, I'm only going to talk about what is highlighted in red, but that doesn't mean that any of these others are not as important. And in fact, I would argue that in some ways the environmental aspects, and if we have time at the end, I'd like to just get into that a little bit. A quick disclaimer, I do not represent any country whose data I analyze. The EU made sure that I put that in, that they do not necessarily agree with what I've concluded. So all analyses and everything that I do with their data is work on my own. So interestingly, the evolution between medicine and agriculture have a lot of similarities over the course of the 20th century. Both became increasingly specialized, technologically driven, both dependent on antibiotics, although the price of medical care has skyrocketed for a variety of reasons. The price of food has decreased, particularly in this country, which is important. I would argue that antibiotics are the foundation of modern medicine. Without safe and effective antibiotics, many of the treatments that we take for granted, like elective surgeries, cancer chemotherapies, immunosuppressive therapies, you cannot do because it would be too risky. At the same time, agriculture and the food security that it provides is the foundation of civilization itself. So the stakes are high here. We have on the one hand the foundation of medicine, the foundation of civilization. So the policies that we implement to address some of these challenges that we face are really, really important. Now, since World War II, the cost of food has decreased dramatically. And so I would argue that most of us here in the U.S. Have been the beneficiaries of this. And we have not experienced food shortages, sky-high food prices. Now, certainly some immigrants from war-torn countries would experience that, but we here in the United States, Native Americans or Native-born Americans, have experienced relatively inexpensive food. Oops. And this is USDA data comparing the percent of expenditures that people spend on food, and we're all the way over here on the right. We spend less for food than any other country, compared to, say, for example, Nigeria, that's spending almost 60% of their income on food. I would argue then that our entire consumer economy depends on having relatively inexpensive food. So without relatively inexpensive food, all the things that people want you to buy, like the iPads and the iPhones and the cars and you name it, if we're spending all our money on food, the rest of everything comes crashing down. So why is food security so important? And I'm going to hit this over and over. They are the foundation of civilization. And when you lose food security, civil society breaks down. And you can see this in Syria. For the several years preceding the Civil War, they had a devastating drought and they couldn't raise their own food. Civil society breaks down. It contributes to it. Food security is inextricably linked with global health, global sustainability, and international security. There would be no global health without global food security. It is really the foundation of it all. Unfortunately, there are many diseases, either directly or indirectly, that are linked to our need for food security. Ebola, Zika, Chikungunya, SARS, Nipah, and in my class, we discuss this balance of the need for food security and safety with global health. They really need to be looked at together. And then, on top of all of this, global climate change affects food security. So in the midst of all these challenges that we face, we're being confronted with a warming planet. Now, this graph is a timeline of the temperature of the planet since the beginning of complex life. But what's so striking to me about this graph is that since the end of the Ice Age, this is the entirety, for 10,000 years, the entirety of human civilization. And what's so amazing is how remarkably stable and level it is on this baseline here, with the exception of a little Ice Age. And then at the end now, this little blip starts going up. Now, the climate scientists are predicting that we can go anywhere from 2 degrees in increase to maybe 4 or more, depending on how aggressive we are in mitigating or curtailing our emissions of greenhouse gases. But 2 to 4 degrees might not seem like much, but when you look at the timeline, 2 to 4 degrees, we haven't seen temperatures like that since the Paleozoic or Cenozoic eras. No human has ever seen temperatures of the planet that high. And it's not going to be good for agriculture. And the reason why we've been able to have civilization is because we've had stable, predictable climate, so you know when to plant, you know when to harvest, and you know when to store. Without that, it all becomes much, much harder. And that's what we're facing. And that's what the public needs to understand, why this is so absolutely critical to the future of civilization. So now let's go back to this aspect on antibiotics. Now, all uses lead to resistance. Let's not, argue that point. In livestock, it's been used for growth, prevention, treatment. Humans, prevention, and treatment. Let me define terms. When I talk about low dose, subtherapeutic, non-therapeutic, growth promoting, they all essentially mean the same thing, and that's about 1 or 2 parts per million for feed. The higher doses then are used for treatment. Now, in the course of the research that I did for this project, one organism stood out, and that was Enterococcuspecium. This organism drove policy in Europe, and so I decided to track it and see what happened, since its rise caused so much alarm. So it's part of the indicator bacteria, part of the normal intestinal microbiome of both animals and people, and can cause life-threatening illness when it gets somewhere where it doesn't belong, like your bloodstream. So the rise of vancomycin-resistant Enterococcuspecium first appeared in the late 1980s in some European hospitals. And then a few years later, VRE was then isolated from food animals in England and Germany, and the assumption was that Vancomycin, which was a growth-promoting antibiotic that was used extensively in Europe and since the early 1970s, was probably the cause of the VRE in the hospitals, because Vancomycin is chemically related to vancomycin. And so it made sense then that if this drug is chemically related to vancomycin, then the use on the farms would certainly then cause the rise in the hospitals. And that was the working hypothesis. So then to just kind of hammer home, Vancomycin, vancomycin are both glycopeptide antibiotics. So Denmark had the best data, and they had a very good story to tell. They were very concerned about the rise of VRE. They used Vancomycin extensively, particularly in their pork-producing region, pork production. They identified VRE in some fecal samples on the farm in 1995. And then they concluded then that they were going to have to change their practices in order to maintain consumer trust and to try to reduce this problem of VRE. So they voluntarily stopped using Vancomycin in 1995, and then in 1997 the EU banned Vancomycin in all EU countries. Then in 1998 Denmark banned virginiamycin, which is chemically related to another human medicine, quinupristin, dalfopristin. And then in 1999 the Danish farmers banned all growth-promoting agents in response to consumer concern. So this is some Danish data, and this is the use of growth-promoting antibiotics, and they stopped in 1999. This is then therapeutic use of antibiotics, so high-dose use, and it unfortunately increased about 120% in the years after they stopped using growth-promoting antibiotics. In 2010, they implemented a punishment system, and it then dropped about 10% and then start creeping back up. This is pork production, and this is human use here in green. So the animals that primarily used antibiotics, about 80%, were the pigs, and chickens less so, and cattle really hardly at all. So when we're talking about this, we're talking primarily about pigs and chickens. So now this graph shows what happened after they banned the Vancomycin in 1995. Then you saw a very nice 90% drop in VRE on the farms. So I want you to remember what this looks like. Nice 90% drop on the farms after the Vancomycin was banned. Now, unfortunately, if you look at what happened in the hospitals, you don't see a nice 90% drop. I mean, the numbers are small, but they kept creeping up. So there seemed to be a disconnect between what was happening here and what was happening in the hospitals. And one would expect that would influence that, but that's not what we saw. So now in the European Union, they decided to ban all growth-promoting antibiotics beginning in 2006. And they established a number of surveillance systems to assess antibiotic use and resistance. Now, unfortunately, for me, the reporting of Enterococcus in animals was voluntary. And there just wasn't enough data to make any analysis, like I did with Denmark's, for before and after these bans. So I can't show you any data in the animals, but what I can show you is some data in the humans, and I will show you that in a minute. Antibiotic sales for food animals primarily corresponded with the size of the livestock production. So for most cases, the countries that were the biggest livestock producers were also the biggest antibiotic users, although not always the case. Some countries had much more antibiotic use even though they might have had a smaller livestock sector. So it appears to be a little bit cultural then in terms of how much antibiotics you use, but not nearly as big a difference as what you see in human use. Now in human use, you see this huge variation in use between the Scandinavian countries that use very small amounts very judiciously versus very large amounts in the Mediterranean countries. Why that is, I don't know. I mean, nobody's really looked to try to analyze. They determined that the Scandinavian countries are using antibiotics much more judiciously and in a much more quality way compared to the Mediterranean countries. Now, interestingly, with vancomycin, this data was not publicly available. I don't know why, but I had to go through a whole bunch of hoops to get it. And I had to sign an agreement that I could not share with you the name of the country whose corresponds with the bars. Why they're treating this data as a state secret, I have no idea. It makes no sense, but I can show you the data, but just not who it corresponds to. But nevertheless, the point is that the use of vancomycin varies considerably from country to country, the way the cephalosporins did as well. And so when you look at then the trend, I tracked out the VRE rates in hospitalized patients for all the years that were available in the EU data set. And the bottom line of this is it's a mess, right? It looks like a mess. So remember that nice 90% drop that I showed you from the Danish data? So what one would expect then after an Vancomycin ban to see a nice 90% drop on all of this. But that is in fact not what we see. What we see is the countries like the Scandinavian countries that use very little amounts of antibiotics have the lowest levels of resistance. And the countries that use a lot of antibiotics, the ones whose names I couldn't share with you, they nevertheless have very high levels. And I can tell you that this is Ireland. They are not a big pork-producing country, but yet they have the highest rates of VRE of all of them. Now, why is that? And, you know, when I correlated vancomycin use with resistance, there was a very nice correlation with human use and with VRE rates. Very, very nice. Now, this is FAO data. This is data that I looked at when I compare pork meat production. This is kilogram per animal looking at the data from before the ban to after the ban to see what happened. And since the EU and the US were the big pork-producing countries, I decided to compare them. And what you see here is this is EU, this is US, and they're fairly close to each other until you get to the overall ban, and then you start seeing a widening effect between the two. Now, so there's a suggestion then that the ban might have had an effect on EU pork production. Can I prove it? No, I cannot prove it. The timing is suggestive, but certainly cannot prove it. Oops. However, if one compares the relative yield between the US and the EU, then there appears to be about a 3% decrease in yield in the EU data compared to the US. And what that would mean then for the pork producers across the EU is approximately a $1.1 billion per year loss in 2012 dollars in lost revenue to the pork producers if indeed that ban was caused that change that we saw on the graph. Cost to consumers is unknown, but according to this International Labor Organization, the price of pork in some European countries is quite a bit higher, generally higher than the price here in the U.S. No effect on chicken meat production, however, because the EU did not ban coccidiostats. No European ban included coccidiostats at all. Now, coccidiostats are an anti-parasitic drug that's used in poultry production, and no ban included them. So they were not impacted the way the pork producers were, if indeed it was due to the ban. Now, interestingly, in the United States, the U.S. never approved avoparcin. And that was because of concerns about carcinogenicity, not because of concerns about VRE. And so as a result, then, the epidemiology of VRE in this country has been very different from what you see in Europe. Congress has spent decades debating the risks of growth-promoting antibiotics. They've consistently concluded that more data was needed, and they consistently never appropriated funds to get more data. And so that left to bureaucratic leaders at the CDC, FDA, and USDA to scrounge together funds to develop the National Antibiotic Resistance Monitoring System and the National Animal Health Monitoring System. Oops. So VRE emerged in the U.S. hospitals sometime in the 1990s. The data suggests that it preceded the European hospitals by about a decade, even though the first cases were reported in Europe. And VRE is an enormous problem in this country, huge problem. 77% of U.S. healthcare-associated infections due to this organism are resistant to vancomycin. Major problem. Americans use a lot of vancomycin. We use 2 times more than France, 11 times more than the Netherlands. And in fact, we are the number 3 consumer of antibiotics in the world. Number 1 is India. Number 2 is China. Number 3 is the U.S. Now this isn't per capita, this is just total. Per capita, for some reason, Australia is the number 1. Why Australia has the highest use per capita in the world, I have no idea. But what's interesting, just as you had this vast discrepancy of antibiotic use in Europe in humans, you see that in the U.S. too. So some states are very high users of antibiotics, and some less so. Perhaps this is due to poverty. Perhaps it's due to the culture of how medicine is practiced. We don't know. Haven't really seen any great studies looking at comparing the practice of medicine from state to state, but they certainly have, according to consumption, vast differences. And it would seem to me that that would be a really important thing to investigate. Now, food-producing animals primarily receive tetracyclines and the coccidiostats here in the U.S. Data has been available since 2009. Don't know which animals received the antibiotics. I would guess they would be similar to Europe, and that would be the pigs would be the primary recipients, but I can only speculate. I don't have data to prove. Now, looking at the data from the National Antibiotic Resistance Monitoring System, or NARMS, they have Enterococcuspecium data. Unfortunately, they don't have data on humans, just the opposite of Europe. But what they do have is they have it on chickens, chicken meat, and pork chops, and in all the years tested, VRE has been 0. From 2003 to 2006, 2002, 11, 0 in all the years tested. Similarly, for the National Animal Health Monitoring System in pigs, 0 in all the years tested, because they haven't been using aviparsin, right? So when we compare then the EU to the US, Europe approved aviparsin in the early 70s, had a huge problem with VRE. The US never approved aviparsin, but still have a huge problem with VRE. So what's going on? So now, up until around 2008, what we've been doing is we've just been tracking resistance genes. And doing that is kind of like tracking people with red hair. Looking, because people who have red hair have the gene for red hair. So if we put all the people with red hair together in a room and try to figure out how they're all related to each other based on their hair color, you simply cannot do it. If you have red hair and you have red hair, that doesn't mean that you're the father of that person. It just means that you both have red hair. But nevertheless, we've been making a lot of assumptions based on microbes possessing these organisms. So since about 2008, the cost of sequencing entire genomes of organisms has dropped precipitously. And so now it's at levels that are affordable for researchers to be able to include in their research projects. So people have been looking at the genome of VRE, and they've discovered that about 1 or 2 clones caused the initial hospital outbreaks. These proliferated into multiple clones, becoming endemic in hospitals, and one in particular was VRE CC17, or clonal complex 17. And it appears, according to this genomic data, that the VRE in the hospital appears to be genetically different from the VRE on the farms, which would then explain why what was happening on the farms wasn't necessarily translating into what you saw in the hospital. And the genetic analysis suggests that this VRE might have come from an animal, but just not the food animal that everyone assumed. Instead, it appears that it might be coming from dogs, that there was a ampicillin-resistant Enterococcuspecium CC17 that they've identified from a few dogs that appear to be the genetic precursor. So now, I didn't even start looking at pets in this. But when you think about it, well, they share our homes, they share our food, they sleep in our beds, our kids are hugging and kissing them. And one of the studies identified the genetic precursor in a 10-year-old boy, and it turns out that he spends a lot of his time hugging and kissing his dog. So it would make sense then that, these animals that there isn't a single surveillance system that includes pets. But, I talked to a lot of veterinarians, and they said, oh, yeah, we see a lot of resistance in our animals. They get a lot of antibiotics, and completely invisible in this whole discussion. So now, where do we go from here? So the question is then, can we have our pork chops and antibiotics too? Well, we recognize the threat. The CDC has certainly highlighted it with their report. And unfortunately, to impact this perfect storm, you've got decreasing number of new antibiotics at the same time as the resistance getting worse. We've had a few new compounds approved in the years since, but certainly not enough to reverse the trend. So now what's been very exciting is some discoveries in the microbiome are are making us rethink how we approach health and disease. So the Human Microbiome Project shows that our bodies harbor many microbes both in us and on us, and the animals have microbiomes too. Excuse me. Now what's interesting, and nobody really could figure out how these low-dose antibiotics work, but what appears to be happening is that some microbes in the gut appear to be positively correlated with growth, and others appear to be negatively correlated with growth. We don't know why. But what appears to be happening is that these low-dose antibiotics appear to be selectively picking off those that are negatively correlated with growth. But we need more studies to understand this relationship. And I would argue then that we can take this knowledge and apply it in a way then that wouldn't jeopardize human health. And that would be to use bacteriophages. Now, phages are the natural foe of bacteria. What we should be doing is working with nature, not against it. So resistance is much less of an issue because this whole CRISPR-Cas9 system is bacteria's immune system, if you will, and the phages have an anti-CRISPR system. So when the bacteria evolves, these evolve too, and they've been doing this tit for tat for millennia. So they evolve with it. They're the most prevalent bioform on the planet, and they might be a very interesting antibiotic alternative. And here's an image of phages attacking a bacteria. And they're very specific, so they provide precision of the exact bacteria that you want to kill off. You can have to use the exact bacteriophage. Now they have been used for approved for food safety use. The FDA approved a cocktail in 2006 against Listeria monocytogenes. But unfortunately, I think there's a potential for its use in food security, but the 2017 USDA NEPA budget allocated $0 for animal zoonotic disease research. So the NIH spends about $30 billion and NEPA gets $0. So is this a One Health approach? I don't think so. I mean, we need to recognize that human, animal, and environmental health are linked. And so if we're going to put all our eggs in one basket in the NIH $30 billion versus $0, we're not going to make any headway here. You know, if we want to try and find an alternative for, you know, animal agriculture, particularly, as I said, with global warming, you know, food security is going to become an increasingly important issue. Funding $0 here is not going to do it. So that's a big problem. So concluding then, there's no evidence that the EU ban in 2006 decreased VRE in the hospitals. Now, I just need to point out, though, that the findings of this organism do not necessarily correlate with other organisms. Each organism has its own unique niche. So what I found here with Enterococcus doesn't necessarily apply with Salmonella or E. coli or any of the others. Those need to be sequenced too, which is why we really need to be doing surveillance of the microbial genomes and not just the genes, because just looking at the genes really doesn't tell you anything. Really doesn't tell you the tree of how these things are spreading. Antibiotic use varies widely between countries and states. And it shows large variations in how medicine is practiced. We need to understand this if we want to try and get all of them curtailing their use to be more like the Scandinavians or the coastal states. Antibiotic resistance in pets is potentially an important reservoir that needs to be addressed. Completely ignored. Bacteriophages are an important alternative to low-dose antibiotics. They're completely natural. They're everywhere. And they could be a potential alternative and would not worsen resistance. But we will never know as long as NEPA continues to get $0 funding to do research in this important area. So with that, I will thank you for your attention. mention, this is my colleagues on the One Health Initiative, Bruce Kaplan, Tom Lonat, Jack Woodall, Lisa Conti, and please visit our website if you're not already familiar with it. It's a labor of love for us, and we love to get as many visitors as possible. So with that, I want to thank you for your time. Happy to take any questions. Yeah.
Question. So what's your view of continuing use of the ionophores?
Well, there doesn't appear to be a human corresponding antibiotic. However, I learned from a veterinarian that it can have some antibacterial properties as well. There is one company that's developing a vaccine against coccidiosis. So, and I didn't talk about vaccines as an important strategy, but you know, between vaccines and phages, I think there's ways we can get around it. But at least until then, I think the coccidiostats are an important adjunct, particularly for poultry production. Now the question is, and what I'm going to be presenting to the Texas cattle feeders next month, what I believe that they're concerned about is you cannot market your product as antibiotic-free if you're using coccidiostats. I think that's the case. Then you start running into problems then in terms of marketing your product if you're using the coccidiostats and you can't say it's antibiotic-free. So I'm not sure how they're going to get around that then. So that's a real conundrum. Yes?
You did a huge amount of digging into the data here, and when we were working on the One Health piece of legislation, the data sharing was a huge, huge message that we heard. What are some of the challenges that you came up against, and what are some of the things that you think would be better to share data across the agency?
Right. Well, in Europe has great data. The ECDC had really great data, but except for the vancomycin. Now, why they made it a secret, I don't know. But I mean, you know, it was not publicly available. I had to sign a whole bunch of forms. I had to submit an application both electronically and by hard copy to them. And I had to promise not to share the data because they didn't give permission, or at least the names. So I don't know why that is. Now, here in this country, antibiotic use data is proprietary by IMS Health. So the data that I got was obtained from another organization that obtained it from IMS Health. So it's rather opaque. And if you want to be able, I mean, I imagine that hospitals know what antibiotics they're using. But outside of hospitals, it would be hard, I think, for practitioners or for anybody outside of a big hospital system to access this data to be able to look and see what they're doing compared to somebody else. So it's rather opaque in this country. And I think that's problematic because really the only way to make advances in that is to compare how you're doing with others and to see if you're an outlier or not. You know, are you using a lot more antibiotics than some of your, some of your colleagues? I think until we start doing that, it's going to be much harder than to cut back. To look at your own practices and see how you can cut back. So thank you for your, I don't know if that answers your question, but.
It's a big question, so.
Yeah. No, it's a challenge because it's proprietary information in this country, and so that makes it more opaque and problematic. Yeah.
So do you think that if all of a sudden pharmaceutical companies started making new antibiotics, that would just actually contribute to the problem? Or would it actually increase food security? Because
right. No, so let me go down this other path then. I mean, I think our antibiotics, as I said, is the foundation of modern medicine, but by putting all our eggs in one basket, we set ourselves up for this crisis. And so that's why I'm advocating for some alternatives, such as the phages. I think the phages are potentially very important and interesting opportunity that's getting very little funding. There seems to be an inherent bias against them because they're viewed as Soviet science. There was a lot of interest in them in the early 20th century, and then once antibiotics came on the scene, interest just completely collapsed. There's only one place in Eastern Europe where they've been continued to be used. but they could be very effective in skin and soft tissue infections, gut infections. I mean, there's some infections that are just would be much more amenable to using the phages rather than to antibiotics. And that would then at least lower the use of antibiotics so that certain infections would be treated one way, the antibiotics in another. It's also easier to get the culture because, as I said, with the phages, you have to know exactly what bug you're working on that you're treating. And some infections, such as lung infections, it's harder to get.
Go back to the good old days when we used phage and clone. You spread them out in the bacteria and know how they're going to die, except they wouldn't help.
Right.
And to me, it's not all that hardly different from the resistance.
Well, so the phages, you've got the lysogenic, you've got the lytic, you've got to work all of that out. But, you know, the technology form is still a century old. I mean, we just haven't made that much headway. I think there's a lot of opportunity there that's just not being done. And, you know, there's very little NIH funding for it, for human medical use, or in NIFA for food security use. I think there's a lot of opportunities there that we're not seeing. So yeah, I mean, you know, we certainly should be developing new antibiotics, but ultimately it's a problematic strategy in the long term because we're going to keep the bacteria can evolve resistance much faster than we can develop new antibiotics. So we need to think more strategically how to live in our microbial world. Why don't we work with nature and let nature help us along, harness this to work for us? Did I answer? Yeah.
How quickly, you mentioned earlier that the bacteriophages can kind of self-adjust to
Right.
account for the resistance that has evolved. How quickly does that happen? And does it actually happen fast enough to prevent the actual resistance from developing?
So this one researcher up at Harvard, John Vigalanos, has done some really interesting work on cholera outbreaks in Bangladesh. And it appears that cholera is cyclical. You get it every, periodically. And apparently in the water of the Ganges River, you have concentrations of cholera bacteria and bacteriophage cholera, or phages that are targeting cholera. And normally they're in a nice balance, but after you get a flood, the phages seem to dilute out. You get a buildup of the cholera bacteria, and then you start seeing people becoming hospitalized with cholera. And it isn't until a couple of weeks that the concentration of phages then start building up to bring down the cholera concentrations, and you start seeing the outbreak dissipate. So from that example, it would suggest to me then that it would take, well, in that case it was diluted out. Now whether or not the cholera bacteria develop resistance, it's not an immediate kind of thing. I mean, there's a lag period there that appears to be the case. Yeah.
When you speak of lack of funding and looking at this concept, what type of funding, how much funding do you think it would take? And when you look at NIFA, I think the reason why I'm going down this road because their SBIR just closed this week.
SBR?
SBIR. And so I'm just curious on how much funding you think it would take to do the work to carry a project out to see how it
Right. That's a good question. Do we have any researchers here? How much does a study like that take?
One study.
One study? Oh, a study looking at phages and on the microbiome of animals? I mean, I would say a couple million at least. A couple million.
Probably a lot more. You have to almost see it as a clinical trial.
Yeah. I mean, you would have to first do the basic science research and then the clinical trials. So you're talking, more than 4 million, certainly, maybe 20 million.
So if you could do the basic, yeah.
Just off the top of my head.
So if you took the concept, and then even if you talk to NIFA has funding for SBIRs, and you do like a phase 1 just to look at the concept, get that approved, and you go to phase 2,
Right.
and then you go to phase 3. You're never get 4 million, but at phase 3 you can get corporations to buy in. So it's just another kind of.
Yeah, I mean, I haven't really looked at how much they would need, but certainly you can tell by zero that it's not going to be enough. It's more than zero. Yeah.
What you do then, following along with how we can encourage to get rapid diagnostics developed, so that the teaching for medical students, for veterinary students, for example, when you're out in the field, what are you going to see? Because you're not doing a surveillance program yet in animal medicine. But we all know that it's so quick and easy to reach for.
I know.
Done,
Well,
and
that's
we're
right.
not following with the traditional, can you get sensitivity and what should you really be seeking?
No, it's a great question because, I mean, antibiotics is sloppy medicine, really, because, you see a patient every 5 minutes, you've got a sniffle, here's your prescription for a shotgun, it covers a whole broad spectrum of stuff, and good luck. I have no clue what's infecting. I mean, in many cases, it's viral. So, you don't even know. And, and that's how medicine is practiced. I mean, on the hospital wards, we used to do gram stains to at least try and figure out what's infecting them. And now it's prohibited. Now you got to send a specimen to some outside lab because of, I forget which regulation, but they can't do it anymore. So now there's absolutely no way. You've got the patient in front of you, you have no clue what they've got. And yeah, it's easy to just write a prescription. It's sloppy medicine, and it affects the microbiome. So, I mean, I think phages would actually require the change of the practice in a better way, because you need to find out what's infecting them, and then you need to figure out exactly what. So it's very precision medicine, really, and it would cause far less collateral damage on all the good microbes that you don't want to upset. So, I think it would necessitate the change of how it's practiced, and it would lead, I think, to a whole industry, I think, of phage centers where you can go and they can, and try and identify what you've got and then, develop a personalized cocktail for you, like what they have in Georgia, in Tbilisi, Georgia, at the Eliava Institute. Yeah.
Sorry, it's following right on from this. 100% agree with you, so I'm not challenging you on that.
Yeah.
But a problem that I foresee with that is that currently to culture and identify takes 2 to 3 days.
Right.
So how do we convince the mother with her kid who's got vomiting and diarrhea to, hang out on IV fluids for 3 days
Sure.
and figure out what it is before we give you anything to actually combat it?
Yeah. No, that's a great question. Well, I know, for example, for like otitis media, they're developing these phage cocktails that can actually go through the tympanic membrane and infect it. So, I mean, we know what's the most likely organism.
Right.
So you can have the most likely organism cocktail, for otitis media and give them something. So, hopefully that would do the trick. But if not, you can, I mean, that's very hard to get culture for with otitis media. You just can't. So, yeah.
So in a sense, this relates to that as well. Nice follow-up here. So you found data with regard to antibiotic treatment practices primarily from hospitals, or was it from primary care as well?
The data that I showed you was from outpatients.
From outpatient.
Right.
And I think honestly that's been one of the difficulties in the discussion about antibiotic resistance, because so much of the data is held in hospitals, and by far most of the prescriptions in the U.S. and other countries that require prescriptions.
Yeah, this is outpatient.
Okay.
Yeah.
Most of the prescriptions, as you know, come from primary care.
Right.
And then there are countries in which antibiotics are available across the counter.
Thank
It's
you.
a whole new layer.
Thank you for bringing that up. The whole issue, this is a global issue. And in many developing countries, okay, so now I'm going to go down this other tangent now. So according to UNICEF, there's about 1 billion people who openly defecate, meaning they go out into the fields and they squat and do their business. Of those 1 billion, about 600 million are in India. So 60% are in India, who are openly defecating. So it shouldn't be a surprise that India has some of the most resistant bacteria in the world because they use antibiotics as a substitute for sanitation and hygiene. And the antibiotics are available over the counter. You know, and I have a colleague who told me, oh yeah, I go home, I stock up, and when I feel a sniffle, I pop a couple pills and I'm better. And it's, you know, and this is a doctorate person, PhD. So, you know, the whole population is doing that. They've got childhood, this is my other talk on the environmental aspects, but, you know, you've got childhood stunning that's off the scale compared to the other countries because they've got such a high disease burden. And they've got rampant diarrheal disease and, you know, it's terrible. And the other aspect that we're not talking about is the environmental aspect. So, you know, you put all of this fecal matter in the soil. Now, most of our antibiotics come from soil bacteria. So we're altering the soil bacteria by putting all this human manure and all the animal manure. We mix it around in the soil. It winds up leaching off into the rivers and into the waters, and it alters the soil bacteria in ways that we don't understand. It's called the global resistome. It's gotten into the wildlife. Birds are flying all over. It's gotten into marine mammals. Sea lions are being found, you know, sickly, starving with antibiotic-resistant infections from the runoff into the oceans. So this is a major problem that we're not discussing that really requires a One Health approach, because this is the environmental component that nobody's talking about, you know?
And it also relates to the data availability that we were talking about, because so much of the data that's been discussed with regard to resistance has been hospital-based data, and that's tiny.
That's right.
Piece of the puzzle.
Right. Well, that's why I looked at the animals, the humans, and the environment in this issue, because you really need to look at the whole ecosystem. You can't just look at the hospital. You really need to see what's going on entirely. And so what's also really interesting is this new area of science called metagenomics. So we only know about 1% of the soil bacteria that we can culture in the laboratory. Most of what's in the soil, we have no idea what's going on. And so somebody came up with this brilliant idea, actually Jo Handelsman did it, she's at OSTP, came up with this brilliant idea of extracting DNA directly from the soil. Now you don't know what bacteria they're coming from, but you can see the DNA, and they looked at it and they found antibiotic resistance genes everywhere. They're in the Arctic, they're in the Antarctic, they're in places that have never seen human antibiotic use. And what that suggests is these genes are ancient and ubiquitous. They're everywhere. And by massively, you know, putting all of our manure and antibiotic waste and everything in the soil, we're changing the global resistome, we're changing the whole expression of these genes. So for a long time we thought that antibiotics were a form of chemical warfare between the bacteria. But it seems to be much more subtle than that. They use these chemicals in very minute concentrations to communicate with each other. And so they have these resistance genes as a form of protection against, you know, inadvertently hurting each other with these chemicals. And so by blasting them with this, they just, you know, naturally responded by increasing their expression. So these genes are out there. It's not like they're developed out of nothing. They're out there by our, you know, stumbling upon antibiotics and blasting the whole soil with it. We're just changing the entire ecology of our planet in ways that we don't understand. So this is a much, much bigger issue than simply too much antibiotic use. So it's very complicated, and trying to get, you know, the public to understand it. And we can't continue just putting all the manure out there. We simply can't. Yeah.
So thinking about how we're blasting the soil and the water and everything else with antibiotic-resistant bacteria,
Yeah.
thinking about maybe perhaps a One Health approach to that, what if we blasted the soil and the water and, you know, put out bait for animals the way that we're doing rabies vaccines, but do it with bacteriophages? Is that?
I was thinking of that. I was thinking that we could somehow recruit the phages to help in a concentrated way.
I mean, as you're talking about